Hello, and thank you for joining the Donut of Destiny. This episode is sponsored by Siemens Healthineers. References to a specific product, process, or service by speakers in this podcast episode do not constitute or imply an endorsement by the Society of Cardiovascular Computed Tomography. The views and opinions expressed in it do not necessarily reflect those of the Society of Cardiovascular Computed Tomography. Siemens Healthineers' Neotom Alpha Class Photon Counting CT enables better diagnostic evaluation of coronary vessels. According to a recent study, 54% of high-risk individuals could have avoided invasive coronary angiography if management decisions were made based on photon counting CT alone. Visualize previously undetectable details in the heart without a dose penalty with photon counting CT. Thank you. And now into our episode.
Hello, listeners, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas. Today, we have a special industry-sponsored episode where we will be investigating a hot topic in CT technology, photon counting CT. And to help with this conversation, I have an expert guest with me today. This is Dr. Matthew Fuld, the Director of Photon Counting CT for Siemens Healthineers in North America. Matthew, welcome onto the podcast.
Praveen, great to be with you. Thanks for having me.
Of course, Matthew, you and I know each other reasonably well, but why don't we introduce you to the rest of the listeners? Could you give us a little information as to your career path in CT and your journey in Siemens to photon counting CT?
Sure, happy to do so. Hi, everybody. Thanks for listening. Hope you enjoy our conversation today. My journey within Siemens has been about 15 years. I started coming out from my PhD, which is in functional lung imaging, biomedical imaging. I was part of our Siemens research and development team here in the United States for about 6 years, with the tail end of that running our first generation photon counting CT prototypes that we had here in the United States, specifically the one at the National Institutes of Health. From there, moved to a business line role where I was responsible for driving Siemens dual source CT business. And now for the last 5 or so years, the initiatives that we have around photon counting CT. So it's been a great journey. Glad to be able to use the technical experience from my research and my days in R&D to advance this topic with clinical users.
Awesome. Matthew, who better than to chat with about this very exciting topic for many of our clinical and research-based listeners? With that said, though, I think it's important to build a background here so that all of us are on the same starting point. Let's talk perhaps about the history of the development of photon counting CT and how it differs from traditional CT technology. I'll let you start with wherever you think is best for us.
Yeah. For cardiac CT, when I think about what's important, the three main pieces are temporal resolution. Obviously, the heart is moving, so we have to make sure that we can stop motion. We have to have good contrast differentiation between the things that we're looking at, whether that's coronary plaque, whether that's calcifications around a valve. But we need general good contrast in the images. And then we need spatial resolution because you have to be able to see the subtleties, differentiate, is something occluded or not? Is it impacting flow? And so we need to channel all of these things. And we've done a lot in the CT industry in the last 50 years to try to tackle each of these, but they always come with the expense of another, right? If you wanted to go faster, it usually meant you didn't get as good quality. If you wanted better contrast or better spatial resolution, you had challenges to achieve that with a clinical level radiation dose. Photon counting is this idea that the field has been chasing for about 25 years that would flip that on its end and has done so. It's a fundamentally different way of measuring X-rays instead of measuring a whole lot of X-rays all at once and having the downsides that come with that, with the X-rays creating a light signal that lose all of their energy information, are spatial resolution dependent based on the size of the detector elements and how we can control light. Photon counting is a radically new invention that allows us to directly measure the energy of every X-ray because we individually measure every X-ray that hits. And it's been a journey of how can you do that clinically? High energy physics have tried to do this and do this effectively for many years, but it's the volume of X-ray photons that you need to measure to create a clinical image that is the challenge. And cardiac CT being something that is temporal resolution dependent, the acquisition time in scans is usually quite fast. And so to develop systems where you can actually individually measure every X-ray that hits the detector has been the goal and the journey. Siemens started 20 years ago in the lab developing new semiconductor crystal technology. This is different than a conventional energy integrating system. Instead of a ceramic that you bake, it's a crystal that you grow. And it has to have the right properties. It has to be perfect. It's a 3-month process. When it fails on day 89, you scrap it and start over. And so it's really dependent on strict controls designed to make it work. From there, it was how do you integrate it into a CT scanner with high enough MA and fast enough rotation speeds where the G forces don't break the crystal or mess up how the signals are processed. And so it's been a journey. Like I said, I started my days in the research and development collaborations. We installed our first generation prototypes of photon counting technology to where we were scanning clinical patients in 2013 and 2014. And then just 7 years later, we're able to introduce the Neotome Alpha, the world's first photon counting CT, which was a dual source CT. So we took care of all of those goals that I mentioned, that the goal for spatial resolution, contrast resolution, and speed all at the same time. But it has been a journey for at least 20 years to get us to where we are today.
Matthew, at the risk of sounding too reductive, this huge journey that the scientific community and obviously Siemens from the industry perspective have taken to achieve commercially available photon counting CT is really a change in the paradigm of the detector element. So to make sure I'm understanding the historic, what you describe as energy integrating detectors, there's the scintillator intermediary. But with photon counting detectors, these do not have that type of intermediary. It's directly converting the X-ray photons into electrical energy. Is that correct?
Completely right, Praveen. The conventional, what we again call energy integrating detectors, was the next evolution after what many people on the podcast might know is the xenon gas detector eras, before we entered solid state CT in the early 2000s. That's what enabled us to do the first cardiac CT. We really needed the rotation times with the rotating gantry, and then we needed a better quality, more stable detector. And the energy integrating gave us that, but it's limited by its physics processes, which is that intermediate light that has to happen. And unfortunately, while we all think of light and the speed of light as something that is extremely fast, it is. But the impulse of light that occurs when an X-ray hits the ceramic is a fixed amount of time. It's about 10,000 nanoseconds. And to do a clinical CT scan with the number of X-ray photons that we do on a regular patient, you have to actually be able to measure an individual photon on the order of 8 to 10 nanoseconds. And so 10,000 and 10 are many orders of magnitude apart. And it means that scintillator process will never be able to offer the same type of advantages as a photon counting detector.
Matthew, you opened the conversation with descriptions of the advantages of photon counting over traditional energy integrating detectors. And I want to start moving now into the clinical perspective and why those photon counting detectors may provide specific advantages for cardiac CT. So let's start thinking about some clinical examples and bringing in the technology you just mentioned as to why it is able to achieve those advantages. You talked about coronary calcium, and this is really the bane of a lot of our existences right now, where blooming artifact in particular from coronary calcium limits our ability as coronary clinical imagers to accurately characterize how bad a particular stenosis is. Could you talk about how some of the artifact we see from coronary calcium can be mitigated with these new types of detectors?
Certainly. We need iodinated contrast to highlight the lumen of a vessel. To make iodinated contrast stand out, we've moved as an industry to going to lower tube voltages on scanners to make that iodine bright and stand out, allowing us to go to lower radiation doses because that's the goal. We don't want to apply more radiation dose than we need to achieve a clinically relevant scan for our patient. The negative is that enhancement of iodine signal also further enhances the calcium signal that we see in calcified plaque. And blooming is the bane of any cardiac reader's existence, right? Is it really 50%, 70%, 80% stenosed, or is it just that there's so much bright halo around a very small structure? And you can't tell that. And there have been a lot of additional tools that have been developed, say, in the last 5 to 10 years from an advanced post processing capability, such as FFRCT, that try to give you more context when it's ambiguous. But what photon counting can do is really push it back further to a higher level step and say, let's actually look at what's happening and can we eliminate the challenge, that blooming artifact that is making it more difficult to read. And it's a spatial resolution problem. And so, with the benefit that photon counting has better contrast, we scan always or almost always at a higher tube voltage, making that blooming relative to the calcium less. But it's because of the drastically higher spatial resolution, the ability even to go down to, say, 0.2 millimeter thin slices, very sharp kernels, traditionally in the past would have been used for, say, bone imaging on a conventional scanner, now are routinely used for cardiac and vascular imaging. It takes what looked like a large degree stenosis and backs that out to what is actually functionally and anatomically present in a vessel, in the heart, in the peripheral structure, doesn't matter. It's the same principle everywhere, but it really gives you that capability to understand. And it is shifting the understanding in the field. There have been a number of studies in the last year or two looking at larger populations of patients that had previously been scored under either CADRADS 1 or CADRADS 2 in the scoring schemes, where they had a high level CADRADS 3, 4. And when they were rescanned with photon counting, that blooming completely changed. The clinicians had a much better read on the real anatomy for their patient, and they were able to lower the perceived CADRADS score. I've seen a significant reduction. Some of the publications show up to a 50% reduction in CADRADS score for patients. And so it's giving readers confidence in what they're looking at and potentially making some of those additional tools less relevant in more cases so that we can really provide clearer answers. The thing that had always struck me, less so maybe at high level academic centers, because high level academic centers will do cardiac scans on almost every patient. But if you are in an office-based setting, an outpatient facility, oftentimes we used a coronary calcium score as a gatekeeper. And if you had a score above 300, 400, people would say, I'm sorry, but your score is too high for us to give you an accurate coronary CTA. We'd rather send you to the invasive cath lab to understand your disease. That's not relevant with the spatial resolution from photon counting. We can now offer the same level of care to whether you have the ideal calcium score 0, or I've seen studies with 6,000 calcium score and they're clear to read for the cardiac readers. So it just changes the game of what tools are in your toolbox and then the level of understanding those images can provide about the status of your patient.
I want to bring back a quick technical question to help flesh out this idea of improved spatial resolution. Many clinical imagers out there are likely familiar with these cases that you're describing with tons of coronary calcium or even potentially stents. And we'll try to manipulate manually the tube energy to slightly increase it. As you had described, we try to select different reconstruction algorithms, reconstruction kernels to get slightly sharper data. But what you're describing beyond this is a fundamental increase in the spatial resolution, differentiating line pairs. Why is that the case with photon counting detectors compared to traditional energy integrating detectors?
It's an important distinction. It all comes back again to that topic of light. Since the detector has to know where the light came from in order to register a signal properly, the detector has these non-reflective septa between the ceramic elements so that you can keep light in a localized area. If you didn't have them, you wouldn't understand where the signal came from, and you would lose considerable amounts of spatial resolution. Since there's no intermediary step with light in a photon counting detector, those non-opaque septa are gone. Why is that important? Is because when you want to increase spatial resolution on a conventional system, you could put in a tighter and tighter grouping of those non opaque septa. But when you do that, your radiation dose drastically goes down because if an X ray were to hit one of them, it doesn't do anything. And so you get to a significant point of diminishing returns where it's no longer relevant to try to improve spatial resolution that way. With photon counting, without the wasted space, the so-called geometric efficiency of the scanner is much, much higher. And instead of deciding the minimum slice thickness based on those light reflecting septa, we can simply choose the size of the ASIC, the application specific integrated circuit, the chip that is measuring that direct electronic signal from the X ray impacts. And you have to do a bunch of physics to balance what is the optimum size so that you don't get physics artifacts. We have come to a conclusion in today's technology that that's around 0.2, really just below that millimeters in terms of isotropic detector size. And that gives us the capability to measure at high speed, which again is important for the temporal resolution, the high MA output that you need in cardiac imaging to scan any patient, while maintaining the desire for spatial resolution, spectral resolution, and all of the things that I talked about in terms of the advantages of photon counting. And so if you took a conventional energy integrating system and applied those wasted space septa, you can do that, but the amount of radiation you would need to apply would be very high. Additionally, when you would then apply a very sharp reconstruction kernel to it, you would get a tremendous amount of noise, because one of the other benefits of photon counting is that we are individually measuring the energy of every X-ray. And so why that's helpful in this particular case is there needs to be a certain amount of energy for an X-ray to go through the patient, right? If it's below a certain energy level, say 30 keV, it would be just absorbed by the body as dose. We often see signals on the detector, whether it's photon counting or energy integrating, at that level. But in an energy integrating system, that's lumped together with all of the noise and all of the signal from the helpful X-rays. With photon counting, since we are measuring the energy of each one, if we have a signal that represents one of those impossible X-rays, we just throw it away. We say, that's not true. And so it allows us to get a much better signal quality by eliminating all of that electronic noise. And so again, it's not one advantage of photon counting. It's many different things that all come together that really allow us to push these clinical fields forward.
So, Matthew, to recount a little bit of what we've talked about in terms of the clinical advantages here, there's a clearly superior spatial resolution. There's the ability to nearly eliminate electronic noise. You had also touched on potentially reducing the dose of radiation that can be delivered to achieve comparable, if not superior quality compared to traditional energy integrating detector CT. Could you perhaps speak to some of the potential applications in cardiac CT? One that comes to mind is like pediatric imaging in terms of dose reduction for these types of exams? Radiations, I mean.
Certainly. I think we all live in a world where we want to have minimal impact, minimal harm, whether that's the amount of iodinated contrast, whether that's the amount of X ray dose that is required. We want to use the level that is needed at a minimum to answer the clinical question. And I think we've had scales balancing over the years to try to decide what is the importance of the information, how well can we trust it, what do we need and what level. And we've pushed it down. I think say 10 years ago the goal was could you achieve a cardiac CT below a millisievert? And I think we've done that and seen that value on the adult side. In the pediatric realm, certainly we see a lot of cardiac CT, especially in congenital heart patients, 1 day olds, 5 day olds, where surgeons need clear answers about the genetic abnormalities, the structures that we're seeing. And we don't want to irradiate these patients at a high level. And so any tools that you can have to lower radiation dose, lower contrast dose, do those things together, give you a lot of possibilities. And with the capabilities of photon counting, that elimination of electronic noise, the better inherent contrast, because we can get a better signal. If you apply the same amount of iodinated contrast, your contrast to noise level goes up, which means to get the same overall image quality, you can lower the radiation dose. So you have a lot of levers that you can pull on depending on where your patient is. If they're an older patient and can't get contrast, well, you can reduce the amount of iodinated contrast. If they're a younger patient and it's really about radiation dose, you can pull down that lever as well. And so we've seen some phenomenal combinations of ultra high resolution and extreme low radiation doses. For me, it's funny when I fly to a customer and talk about this and I show cases on some of these patients and I'm like, yeah, I got more radiation than this coming here to see you today. but I'm happy that this patient did not. And so it's really we're at that level. It's quite remarkable what we can do. And we're doing it without compromising the quality. That's the most important thing. People can always lower the radiation dose. You can turn that knob down lower. But what are you getting when you do that? And fundamentally, it's about the hardware. And there's been a lot of hype of the use of AI and machine learnings, and Siemens is certainly one of the leaders in that space. But it all starts with hardware. And if you don't have the right hardware, you can't push it any further with additional technologies. And really, photon counting is one of these things that is a dramatic leap in capability that will offer us the ability to do more. And certainly people will and continue to apply technologies, enhancements, AI on top of it to take that technology further. But fundamentally, you start with the hardware. And we're proud, really, of what this can do for pediatric patients. Dual source CT in general had been the gold standard for pediatric imaging, pediatric cardiac imaging. Now, dual source photon counting really has taken that the next step. And I'm happy for that. I'm biased, but the local hospital near me is getting one as well. So I'm happy in case my kids ever need it, they have the best quality of care able to them.
Matthew, we could talk about the clinical impacts and advantages of photon counting CT for honestly hours. A lot of our clinical imagers in our audience have probably seen the images, and those are frankly self-explanatory for the advantages you get of the challenges that we previously had with coronary calcium, with characterizing in-stent stenosis, with tiny branch vessels, characterizing plaque, even tissue characterization like myocardium. But we, as clinical imagers, are really just one part of the care team. I want to move now to talking about our technologists. technologists, at least in the sites that I work at, they're often bemoaning the various buttons they have to press, the buttonology and large number of clicks that are needed to get really high quality cardiac CTs. So now we're introducing a pretty advanced piece of hardware, pretty advanced technology with photon counting CT. Does this mean potentially that our technologists are going to be even more encumbered by buttonology, more clicks, more advanced understanding of how to work this machine?
Let's just say I'm happy that our technologists are using the products that we have available today. If you had asked me that question in 2014 with the R&D prototypes where we were doing reconstructions in MATLAB coding and twisting things on the scanner, it was chaotic. It was complex. It was trying to understand, how do I calibrate and do energy setups for this? Are those the right energy thresholds? Siemens has done all that work. Now it's how to take it and make it clinical and functional for any environment. And Siemens introduced technology, what we call My Exam Companion, first on our energy integrating detector systems. It's across all of our fleet of new systems that run on our Samaras 10 platform. It really makes it simple. The whole idea was to eliminate the concept of a super tech. Don't get me wrong. The technologists are critically important in this workflow, but I want them to focus on the patient, not on, did I remember to flip that switch or turn that knob? I want them to make the patient calm, make them ready for this stressful day that they're going through and getting this image. And so My Exam Companion takes the complexity out of it, and it eliminates even some of the things that people would have said in the past were potentially challenging obstacles, even with a dual source CT, like a definition flash or force that was on our previous operating environment. Why is that? Because we were still developing cardiac CT as an industry back then, and there were always new innovations trying to understand how they would work in workflow. Do you want a single phase flash scan, lowest dose, fastest acquisition? Did you want multi-phase cardiac for doing a valve evaluation or for somebody in AFib? Do you change it for prospective step and shoot? Those were individualized protocols on our conventional scanners on the older platform. With the technology that we have today, it's all in one, and there's nothing that the user needs to do. The system will automatically measure the heart rate and rhythm. You can enter in clinical factors directly from the wrists or through the technologist simply answering a clinical question, such as, have they had caffeine today? Well, if they've had caffeine, maybe their heart rate's going to be higher. You want to use a different scan strategy. The technology has the ability, if you are still in that mindset where you want to use calcium scoring as a gatekeeper, and some people do, maybe you set a threshold of 700 or 800 calcium score, and it can automatically calculate vessel specific calcium score. And based on that, change the scan mode, whether you want that high speed, single phase, single heartbeat image. Do you want ultra high resolution with spectral? It can automatically change all of that, transparent to the user, nothing that needs to be done. And that's on the acquisition side. And then on the reconstruction side, it makes unlimited numbers of reconstructions. It does it automatically. It does all of your reformats, your spins, your MPRs, your curved reformats. It can automate all of the spectral analysis, send those directly to PACS for you, really making it simple for the operator to do exactly what we wanted, which is spend time with the patients. Even more recently, a new technology came out that is, again, now available across our conventional energy integrating and photon counting scanners, is a technology that we call Z-Free. So this was the other thing that people pushed back on, saying that you need a wide area detector to capture the heart. Z-Free automatically eliminates, through a deformable image registration process, part of the image reconstruction, and automatically aligns any movement between adjacent acquisitions, whether it's in a prospective step and shoot or it's in a retrospective spiral, it automatically aligns the anatomy. And so there's no longer misalignment. That had used to be something that a technologist would have to manage. No, oh, there was misalignment. I need to adjust this before I send it to my cardiologist, radiologist to read. This is done automatically. It's just part of the standard image reconstruction. It's what many of our collaborative post-processing image vendors, FFRCT, plaque analysis vendors, they say, please make that the default. It makes our software more accurate and more efficient. We want you to use that. And so it has to be about everyone. It has to be for the cardiac reader so that they can make more confident decisions. It has to be about the operator, those technologists, and it has to be about the patient, right? The whole goal of photon counting is to give clearer answers for patients so there's less ambiguity. There's less, Mrs. Jones, please come back in 3 weeks because we don't know what we're doing. We need you to get another test. We want to get them an answer right away so that we can lessen their burden in their healthcare journey.
Fantastic. From the global technologist perspective, I think the idea that this new hardware, this new technology is not going to complicate, but potentially even lighten the amount of workload that you have is really beneficial for future workflows and potentially access to care.
It really does. And maybe one anecdote to highlight is when we introduced that new My Exam technology workflow, we brought a series of technologists who had never scanned cardiac, never scanned on our newer platform, but were familiar with our older Samara 7 based platform, brought them to the factory and said, here you go, sit at this scanner and do a cardiac scan. We turned on all of the automation, all of this My Exam companion technology, and at the very first attempt, 82% of them did it right. On the second attempt, they all did it right. We took them out to dinner, had conversations, brought them back the next day, and turned off all of that automation and AI support. And 82% of them failed to do it correctly. So you can take somebody who had never done a cardiac CT examination, never seen the platform, give them the tools, and make them an expert almost immediately. And so it really has value, again, trying to get rid of cardiac Tuesdays, trying to get rid of that super tech only methodology so that we can really push the boundaries and make this more accessible everywhere.
Matthew, I think that's a good dovetail into the next topic that I wanted to cover, which is access to care. If we are effectively eliminating technologist resources as our choke point in access to care, we got to just get this hardware out there. It's got to be put into clinical sites. The question is then begged, is it the same as putting in a traditional energy integrating detector in a particular location? And if not, what are some of those siting differences for putting a photon counting CT in a healthcare institution?
Sure. I jokingly mention, as an engineer physicist, in many of the conversations I have with customers about this technology, that this is a CT scanner. It's not a tricorder, right? It's not a future device from Star Trek. It is a CT scanner at its heart. And so the fundamental design and installation of this scanner is consistent with our scanners that we have across our portfolio. The ones most likely to be desired by this audience would be dual source CT. And dual source CT has historically been water cooled systems with the Somatome Force flash drive. Our Neotome systems are also water cooled, and we have a variety of different options depending on the location, whether you have hospital chilled water or you're in an outpatient clinic and you stick a water chiller on the roof. And so it is a very simplified design, even compared to previous generations, where we've endeavored to bring more and more of the technology that is in a technical room, such as power distribution cabinets and things, into the design of the gantry to make it simpler, make it all in one, reduce the overall service burden, reduce the preventative maintenance time required for these types of things. We really can make efficiencies in a lot of areas, and we've done that with photon counting. The only caveat to photon counting, because everybody will always say, well, it can't always be perfect sunshine. You're not telling me the truth. Photon counting detectors, because they are a semiconductor crystal, they operate when they are at the appropriate temperature. And when they cool down, their electrical properties change. And so we treat a photon counting CT just like you would treat an MR. You don't ever turn it off. You always keep it on so that it maintains its power around its semiconductor and keeps it at operational state. And so that's maybe the one big difference, right? At the end of your shift at 6 p.m., 7 p.m., you don't shut it off and then turn it back on the next morning. You just leave it on. And we continue to work and develop new technologies for low power modes, downtime, ramping down of the energy consumption so that we are mindful from a sustainability perspective, but we keep the thing on at all times, just like an MR.
Got it. Two quick follow-up questions with that. Does it take a long time to start back up in the case of a downtime, say like a power outage at the healthcare facility? And then second, is it a significant power draw to keep it on all the time, or is it a relatively small power draw?
Yeah, and those are very good questions. The significant power draw from a CT is when you're using the X-ray tube to scan a patient. The amount of energy in this idle state to keep the detector on is not a high energy load. It is a small fraction of the overall amount of energy that is used in the scanner. It's just a different workflow for facilities compared to a conventional energy integrating system. One of the things that we want to do is make sure that this is robust in all environments. And when we started this technology in 2021, we were cognizant that we never want to install this in an emergency department, in a level 1 trauma center on the first round, because you want to get the kinks out. You want to make sure that there's not anything there. We're well past that, and we have now these systems running in 24-hour facilities, in emergency trauma facilities, because we've also thought through that process. And so with every one of these systems, we deliver what we call an always-on UPS system. It's a box that houses a couple of batteries. It's also where the image reconstruction system, the IRS, is housed. It's all one box, small, that's in the technical closet for the room. And it maintains power on that detector system for up to 15 minutes at a time during a power loss. Now, in a hospital environment, typically there are regulations in terms of power shifting from main power to backup that are under 10 seconds, right? Channel the ventilator that your patient is on, that infusion pump, it can't be off for a long amount of time. So 15 minutes is typically overkill for that transition between main power and backup, but it gives that flexibility of an environment where maybe you're doing monthly testing in terms of your power response and turning things off, turning things on. It gives you that flexibility. Really, it's only if we lose power beyond that 15 minutes that there's any waiting time. And the amount of wait to resume really depends on how long you're off. If you're off only a few more minutes past that, we request that the system has time to get to a stable state. It's an hour, and then you can start scanning again. And so it's not really anything that would impact clinically in most scenarios.
You had alluded to the fact that these scanners are now extending beyond the large academic sites, large academic institutions in which the both prototype and then the subsequent first models were delivered. To my knowledge, these are still relatively large healthcare institutions in which they're installed, and therefore there aren't that many out in the community. Could you perhaps speak to what the current access is to this and why the landscape is the way it is?
Sure. For Siemens, we truly believe in this technology. But with every new technology, there is an adoption curve, but you have to set a goal. And for us, that goal is to ensure that Siemens CTs are all photon counting CTs by 2040. So 15 years. And that will be a ramp up period across the technological platforms, the accessibility platforms. We have scanners starting, from the Natum Alpha going all the way down to scanners that many of these listeners would never consider because they aren't cardiac CT capable. And so I would say really the midpoint to the high end is where our users here, our listeners would care about. And I would imagine that level of technology will be much sooner than 15 years. But you got to start somewhere. And so we're approaching 100 scanners already here in the United States, more than 200 worldwide. And that has been through the adoption of the first photon counting CT, the Natum Alpha. But we are excited and proud. We launched at RSNA this past November, December, the Natum Alpha class. It is an entire fleet of photon counting scanners, 3 different systems. One single source system does really great cardiac if you can beta block your patients, control heart rates, and then 2 dual source configurations, both having the same temporal resolution that all of our listeners would want at 66 milliseconds, just different detector coverages, 2 4 centimeter or 2 6 centimeter detectors. And so those are FDA approved. We got approval in February. We're very excited about that. We will have first deliveries coming up soon. And so with the ability to now have a scaled technology investment based on the types of patients that you're hoping to do in your practice, whether you want single source for, say, an emergency department and as a secondary cardiac scanner, or one of our 2 dual source configurations of the Natum Alpha class, we expect to see a significant ramp up of this technology. Now, the installed base of CT scanners in the United States is quite large. I would say somewhere in the 10,000 range. I'm not 100% sure the exact number there. Not all of those are cardiac capable. I would say more than half probably are not. We could have a whole discussion about access and disparity in locations, but we expect the prevalence of photon counting technology with the Natum Alpha Prime, Natum Alpha Pro, and Natum Alpha Peak to rapidly expand. We are eager to see what our fellow innovators in the market do. We hear a lot of rumblings of photon counting CT coming from other vendors. And I think that's great because that just means more people are seeing the value of the technology. And I think it will become more prevalent to our patients across the country.
So, Matthew, we've covered a ton of ground here in this conversation. We talked about the technology behind photon counting CT. We talked about the advantages from the clinical perspective in cardiac imaging and really just CT imaging altogether. We talked about the potential advantages in technologist workflow and how we can increase access to care to the patients that would really benefit from this type of technology. So as we come to the close of our conversation, I wanted to ask you what you think you're most excited for in the space of photon counting technology.
For me, photon counting has been a goal, right? It's been the North Star for the computed tomography community for the last 20 years because of this vision of no longer having to compromise between, one factor or another, spectral information, spatial resolution, temporal resolution, quality, whatever it is. This is now enabling us to have a level of quality, a depth of insight into our patients that we've never had before. And what excites me is the new questions that we will be able to ask and answer, the new pathways of care that we can enable so that we can get answers for patients more quickly without waiting time, without the follow-up cath lab visit or nuclear scan. It really is one of these technologies that you can directly look at and say, yes, this is going to have a distinct impact in my patients, and I'm proud of that. And so I think Siemens Healthineers is really excited to be in the position that we are. We see all of the innovation in the community around acquisition, around interpretation, hinging on the quality of photon counting CT because it gives us that depth of information that lets us ask the questions we could never ask before. So it's a very exciting time.
Awesome. Matthew, thank you again for coming on the podcast. Obviously, we both have a passion for this particular topic, but the cardiac imaging community broadly is super excited about the direction. And I really appreciate you dedicating your time to at least this, in addition to all of the other contributions you've had. So super thanks again and kudos.
Thanks, Praveen. Happy to be here. And we're happy to talk about this technology anytime.
Awesome. Thanks again, Matthew. Of course, for our listeners, thank you for tuning in. If you like what you hear from this podcast, make sure you rate, review, and subscribe to it. That's how others out there find this content from Dr. Fold and others. Once again, this is the Donut of Destiny. Cheers.